right now.
Excellent. Hello, hello, and good morning, everyone. Welcome to the third annual People of Color Living with Diabetes Summit. My name is Quisha Umemba. I am the current president and the co-founder of Diversity in Diabetes. The theme of this year's summit is diabetes in the real world. This year, we not only want to shed light on the everyday challenges faced by those living with diabetes, we wanted, more importantly, to celebrate the everyday triumphs for people living and thriving with diabetes. So in case you are not familiar with our organization, for the past 3 years, our goal at Diversity in Diabetes has been to educate, empower, and advocate on behalf of those that are often unseen and unheard. And specifically this year, our work has demonstrated how investments in prevention and management of virtual education and support can benefit vulnerable populations and lead to improved health outcomes in people with diabetes. We really do strive to ensure that every person, regardless of race and ethnicity, has the information and the opportunity to thrive with diabetes. And we will continue to advocate for diabetes-related health disparities and work toward achieving health equity for all people of color living with diabetes. Stephen Covey said that strength lies in our differences, not our similarities. I ask that we all remember that today as we witness and celebrate our diabetes community over the next couple of days, while people share their experiences with diabetes in the real world. And I speak on behalf of myself, my co-founder Grace, and our board member, my co-founder Casey and our board member Grace. We're so glad that you could join us for this year's summit. Now, there's a few people that I do need to thank before we get started, and that's our wonderful sponsors that have supported us in this year's summit. Thank you to Omnipod, thank you Medtronic, Lilly, JDRF, Risley Health, MMNT, pronounced Movement, the Diabetes Link, Dexcom, and Sanofi. Secondly, I have to thank our speakers and our community panel groups that are going to be sharing their expertise and their time with us this year. And last, I want to thank all of you that are joining. We cannot do this without you all. And so we're grateful that you're sharing your time over the next 2 days. And we hope that you find value in these sessions and something that you can use in your life or in the lives of others. With that being said, I'd like to now introduce to you our speakers for the hours. And so I'm gonna pull up my, sorry. I'm gonna pull up the agenda and introduce our first speaker. Erica Erickson, if you wanna go ahead and share your screen now with your slides, you can do that, is joined with Amanda Kaufman and Mr. Edward Hawthorne. And they're gonna be providing us with a review of the diabetes policy landscape and how you can influence legislators to act on behalf of the diabetes community. Without further ado, I'm gonna turn it over to you all. Thank you so much.
All right, so Erica, you want me to get started?
Yes, please do, Ed.
All right, well, good morning and welcome. My name is Edward Hawthorne, and I have been a diabetes volunteer and advocate for over 3 decades. Past chair of the National Board of the American Diabetes Association, board member for Children with Diabetes, and I currently serve as vice chair of the Diabetes Leadership Council board. Now, who is the DLC? Well, we are people with diabetes, parents of children with diabetes, allies, and tireless volunteers dedicated to improving the lives of all people impacted by diabetes. The Diabetes Leadership Council unites former leaders of national diabetes organizations dedicated to securing effective, affordable healthcare and a discrimination-free environment for every person living with diabetes. Diabetes is a common thread connecting DLC volunteers from different backgrounds, professions, geographies, political persuasions, and these diverse experiences and areas of expertise help the DLC examine tough problems from different perspectives to find consensus solutions. And what do? We convene, we collaborate, and we communicate through our experienced and passionate advocates to engage policymakers and public and private sector influences, breaking down barriers for care for over 37 million Americans with diabetes. You can check us out on our website at www.diabetesleadership.org. Now, before I get the hook, let me introduce Erica Emerson, DLC's diabetes from the Diabetes Leadership Council. She's our Chief Policy Officer, and Amanda Kaufman from DPAC. She is the Health Policy Content Creator, and they will lead us through today's presentation, the T on truthiness in diabetes policy advocacy. So Erica and Amanda. Now, Amanda, your title was that was a mouthful.
It's still in the works.
We are very excited. Amanda first joined us as a part-time policy associate and came to us from the now the Diabetes Link Next Gen program. And we were very excited to bring her on full-time, effective now.
Thank you. Effective to be decided, but thank you. I'm really excited to be here. Thank you.
All right. Well, good morning, everyone, and thank you for joining us for a little morning tea. I've got mine, a little tea and honey, to make sure I keep the vocal cords ready for our chat today. A lot of times when we talk about policy and advocacy, we can get really nerdy and down into the weeds. We're going to try and keep things light. It's early in the morning. We're at the start of this very exciting virtual summit. So we're going to focus on a little bit of the tea, a little bit of backstory about what the landscape looks like in policy and advocacy, what some of the challenges are within the diabetes community, and frankly, within the country, trying to advocate for better healthcare, more equitable healthcare for all Americans. And we'll see where we go. We're going to, again, keep this interactive. So as questions come up, please put them into the chat. We will also be asking some questions of the audience. So again, this is our presentation and yours. So let's go. So since we're talking about tea and truthiness, we're starting off with this quote that is lesson number 1 on the first day that you are a journalism student. You are taught that way back when an editor said, if your mother says she loves you, check it out. Now, this isn't to disparage mothers. I am a mother. I know that when I say that I love my kids, they ought to know it. But what this really is about is making sure that you have your information, you have your facts right. And the kicker is this, this actually is a misquote. So as much as, journalism students are told to check their facts, what the actual quote was if your mother says she loves you, kick her soundly in the shins and make her prove it. Now, I'm not advocating that. Don't kick your mamas. But again, just a lesson in making sure that when we go out into this wide world of advocacy in person and online, that we have our facts right. So again, this wonderful internet is a place where we have incredible access to people and information, but it also means we are at the risk of falling subject to misinformation. So today we're going to talk about the usual suspects, where that information and misinformation comes from and what their motivations might be. We talk about why our brains want to believe information, even if at our deepest gut level, we know that it's maybe not right. Or we say, oh my gosh, how can people believe that? Like this is an others problem, but this is actually something that all of us as humans are prone to fall prey to. The impact on people with diabetes, and in particular diabetes health equity, and what we can do as advocates, as individuals and as diabetes advocates. So here we have our usual suspects, and we see here that we've put them kind of on a spectrum of well-intended or means well misinformation, all the way up to liar, liar, pants on fire, disinformation. Now, Amanda, you have shared in the past that you are super fond of getting unsolicited advice about your diabetes from strangers. Can you tell us what some of that information, helpful information looks like?
Yeah, so I think there's a lot of information on the internet about diabetes, home remedies, that kind of thing. And that's the kind of information where like maybe a well-meaning Facebook post, Twitter post, or even a well-meaning relative sharing a Healthline article about, for example, how cinnamon is essential in diabetes treatment, this can turn destructive when this is amplified to a viral or even just a high profile level, because it kind of undermines the need for real life policy changes when everyone thinks that, well, really what people with diabetes need is to just eat cinnamon, or just, get their diabetes under control, get their diet, get their exercise under control, when there's so many more factors than that.
Lifestyle changes,
Yeah.
right? Yeah. Super frustrating. So, so we would right now, if you have a favorite peeve, a least favorite bit of diabetes misinformation that you have helpfully received from well-meaning moms, dads, family members, nanas, everybody, go ahead and put those in the Q&A and we'll share those as we go. So again, we have the well-meaning information sharers. We have the spreaders of cinnamon, folks who frankly develop content, spread content, and either don't know better or they don't check their facts. Again, we kind of chalk this up to misinformation. This happens even in the media, particularly with kind of shifts in media moving to more online platforms and less local news, less rigorous reporting. So again, well-meaning, not so helpful. We've got the ever-present trolls who are going to troll. These are just people who are online looking to get a rise out of you. And then it really is just up to you whether you engage, although I would soundly recommend you just let it go. And then again, we end up with liar, liar, pants on fire. We have the spread of deliberate misinformation, and that is spread where, again, we're going to set politics aside for today and focus on diabetes. It is spread intentionally to influence what we think and do. So why do other people fall prey to misinformation? Frankly, we all do it. And this really, we're going to keep this super light. I'm not a neuroscientist. I'm, just a policy nerd who's kind of interested in learning on why a lot of this information and misinformation grabs hold, particularly as it relates to advocacy. So our brains have a bias toward a happy place. So when we experience information, instead of looking at it objectively, we try to file it into what we already believe. And when something doesn't confirm what we believe, we ignore it or we tend to forget it. So once we sort of lock into what our beliefs are, we selectively focus on the information that validates it. And we, again, tend to sort of set aside information that doesn't make us feel better. We look at information with a very specific lens, and we interpret it accordingly, which means when we look at the same information, people can come up with completely different interpretations based on their own kind of preconceived notions, whatever lenses they might have. You get a lot of confusion, a lot of misunderstandings, again, based on our own biases going in. And again, as I mentioned, we've got biased memory. So we tend to remember the things that make us feel good, and we forget the things that challenge us. But when it comes to advocacy, sometimes our strongest learning is when we are challenged and when we are exposed to people who think things differently or who pull us out of our echo chambers, because everything we see online is meant to be sticky. It's meant to pull us in. So we go to a certain website where we click on a certain email. And every time we do that, every time we engage, we end up working into algorithms online that work on websites, on our email. And as those algorithms take hold, these media sources tend to start targeting us with information that they think we will like or we will engage in. So we get really clickbaity headlines, which encourages us to just keep scrolling or doom scrolling when we should be going to bed, and we just can't put our phones down. They want us to come back and get more of that information and share it with our friends. So again, a lot of times information is packaged in such a way to just make us mad or make us happy, but mostly make us mad because we tend to share things that anger us more than we share things that lift us up and make us happy. So the more time we spend in these echo chambers, the more we tend to lock in on what we already think, and we ignore the facts that challenge it. And sometimes that means we get deeply entrenched in things that are wrong. People can deeply believe that the earth is flat, but that doesn't make it so. So it's really important when we really, really believe things that we challenge our thinking, challenge our learning, and challenge our information to make sure we've got our facts right. Because we see here, again, we are a very polarized country. That's not helpful. It's not helpful for our health. It's not helpful for our country. These are wide-ranging effects of the stickiness. Now, Amanda, I see we've got a whole bunch of stuff in chat. Would you be able to share?
Yes,
some of the P's?
People are talking about things that they have heard that people tell them about their own diabetes that are incorrect. We're starting off with someone saying, you have type 1, that's the bad kind, right? And that's such a common thing that I've heard, good kind, bad kind of diabetes.
Good kind, bad kind, yeah.
Like, never mind the fact that why would you say that to someone? It's incorrect.
There is no good kind, yeah.
And then my grandmother does a teaspoon of vinegar a day for her sugar. That's, I feel like, a common, I've heard that one as well. If you just work out and eat low carb, then technically you wouldn't need insulin. Not correct.
Not correct.
Someone said, my mother-in-law thinks only sugar can raise your glucose. I feel like that's a common one, like using the word sugar in place of anything related to diabetes. Mother who is a massage therapist saying, I can cure your children's type 1 diabetes with deep tissue massage. Someone saying that's a new one. Oh, and someone saying, I've been told I'm so sorry that your mother gave you too much sugar when you were so little. I wouldn't know how to respond to that one. Someone saying adults can't get type 1 diabetes. It's a childhood disease. That's also something I've heard. Let's see. Oh, someone talking about Facebook diabetes group, and everyone's advocating for keto, the keto diet. I've even had other people with diabetes tell me to go on the keto diet. So
go on the keto diet.
Yeah, or you're too skinny to have diabetes. That's another one. Yeah, people, I appreciate people saying this because it makes me feel as someone with diabetes,
not just you.
Yeah, I feel oh no, not that comment. I mean, just I feel better knowing that people are experiencing the same thing, that everyone's saying these kinds of spreading misinformation to them as well.
Yeah. I think it's good learning that when you are within the diabetes community and when diabetes is your personal reality, it just becomes so second nature, and you have to be an expert in your own diabetes. But for people who don't live with the condition and don't understand it, it's one thing to be helpful on Facebook, which is really easy to ignore. It's a lot harder when the people who have those misunderstandings are policymakers or our employers or other people who make really important decisions about health. So again, as humans, we like to blame things on bots and algorithms and what have you, but realistically, when there's false information on the internet, including Twitter, Facebook, etc., it tends to be humans who spread misinformation more than computers. So we wanted to do just a quick lens check here. We always look at, well, when people get really mad about something, that's when they tend to share it. So we're going to use our personal anger thermometer here. Look at this sign, and let's see if we can get a couple people to weigh in on, do you look at this sign and say, no big deal, or what is your first impression? I will say this is a photo that was shared on Twitter recently. And it sparked a very long string of very strong emotions about why a public venue would ban people during a pandemic from wearing masks. So it became a whole thing. There was quite a kerfuffle until someone pointed out, let's go to the chat, scream. I'd say angry with a significant eye roll. All right, I love that. Okay, so unfortunately, this picture was shared as though it was current, and it's over 2 years old. So this sign predates the pandemic, and it was created for a public venue to ask people to please not wear Halloween masks so that all patrons of this area could feel safe. Now, you could say that the employee who put this out or the organization that kind of runs this area could have put Halloween masks. But again, it just became one of those things that was just humans being humans. And as the story spread and as the context changed, it got people very whipped up over something that maybe was a little less dramatic than it otherwise would have been. All right, here's another one. Again, true story. This popped up in Colorado, I think last year or year before, and caused a very big kerfuffle, at least on the areas of diabetes Twitter that are in my feed. So if anyone wants to weigh in with an angry eye roll or what have you, because we all have very strong feelings about people with diabetes who are discriminated against at work, school, or really anywhere. Now, this is one of those stories that grew, grew on as a spread on Twitter. This was a teen who was disqualified because he was wearing a CGM. He was disqualified. He was a member of a relay team. So not only was he disqualified, but his team was disqualified from the state championship until folks started actually reading the story and reading beyond the headline, which could be very clickbaity. There we go. Makes me mad, but also sad. But here's the thing. He actually was disqualified, not because he had diabetes, but because his coach didn't file the medical exception that all swimmers with external devices or anything external needs to file to swim, to explain that this was indeed medical and not to influence their buoyancy or whatever. So it actually makes it safer for these folks to swim so that it's not up to individual coaches to make the call that says, I don't know, will this help you or not? So it was a policy that was intended to help swimmers with disabilities or medical conditions. But you end up with a young man with, I'm sure, hopes and dreams of swimming in a state championship who wasn't able to do it because of paperwork. So again, when we see these things on Twitter, when we see these headlines that make us go, it's really important a lot of times that we just stop and take a breath. Because when we look at all of the news that's out in the sphere, again, particularly with the dearth of local newsrooms, these are the venues that are popping up to fill those voids and to fill those needs we have to learn or to be heard. This is just a screen grab. That's there's actually a really cool interactive tool at a website called Advocacy Media, and you can go in and click and just kind of see of the sources you have for news, where do they fall on this spectrum? Now, I'm sure there are other metrics out there, but this I just found particularly helpful. And frankly, I heard about it from my kid's social studies teacher. Because kids right now are getting training on media literacy and how to be more discerning of what they see online. It really is adults who frankly could use a bit of this training as well. So hopefully we'll get a bit of that in today. But you have here a spectrum that sees, one, how partisan we are or how split we are left to right on the partisan views of the news sources we use. But there also is considerable gap between what is accurate and what is completely made up. So this isn't to say that you can't go to Wonkette or Fox News, or wherever you want to get your news, but understand the biases, understand how those channels might be kind of framing information in a way to keep you hooked, to keep it sticky. And when you see something that makes you mad or makes you curious, the way to validate it isn't to go across and, look at another kind of similarly or oppositely biased news source. It's to go up to the top and look for those sources that tend to be a little more fact-based. Now, there's a wealth of information and organizations that really do a very good job of providing fact-based learning for some of the issues that impact us in diabetes and diabetes advocacy. Here are just a few of our favorites. Thank you, Amanda, for putting that website in there. If you have some sources of information that you like to go to, put those in the chat as well, and we'll share those. These are, frankly, just some of, I call them nerd reading. As a policy person, this is where I like to go when I need to learn more or understand more. So those are my ideas. And again, these slides will be available after today. All right. So Amanda, I'll let you check the chat, and if there are other news sources that people want to share, we'll go ahead and do that. But now we're going to pivot, and we're going to talk about how information and misinformation impacts our health, the diabetes community, our policy making, and our abilities to vote. I think, what we cannot ignore as we go through this conversation is, one, the systemic and structural racism that exists, and the fact that information can be weaponized or used not just to impact people's health, but their ability to vote, or their political influence, or their place in the world and their feelings of safety. So what we're trying to do, again, is to disarm the use of misinformation and focus on accurate information. Sorry, there we go. We're a little bit slow. So this is not going to be news to anyone, and I know we have a full lineup of other speakers during the summit who will get into some of the disparities, but I'm quite confident these are very familiar to a whole lot of you. The burdens of diabetes are not felt equitably or equally amongst different populations within the United States, and communities of color, by and large, are experiencing less access to diagnostics, early screening, treatment, etc., that are impacting their outcomes. So again, we see different burdens of this within different communities within the United States, but we also see, I think, when we're looking at solutions, we have a really hard time even looking at data beyond Black and Brown, right? Or we talk about Hispanic or Latinx communities, when there are very distinct communities within the community. So when we're looking at solutions, we want to make sure that all of these people, everyone, is represented. And right now, I think within our diabetes advocacy community, we have such passionate people, but a lot of the faces that are missing, a lot of the voices that are missing, are folks from Black and Brown communities. Again, so Asian descent, Latinx, Hispanic, African-American or Black communities. Everybody has a distinct voice and has a distinct journey with diabetes. They have their own experiences, and as much as it helps us, for example, as a policy organization, talk about high level, what really makes a difference in advocacy is combining those facts with the voices and stories. That's what really makes it real for policymakers. So we know that insulin is not something that everybody in the diabetes community requires, but it certainly is one of the topics that takes up a lot of the oxygen in the room, partly because we've actually made a lot of progress in this past year and really the last couple of years in radically changing the landscape and actually starting to get hopefully some legal protections in place to make sure that people can afford their insulin. Now, again, we always preface these conversations with saying that DLC and our sister organization, the Diabetes Patient Advocacy Coalition, We believe that all diabetes care is preventive and should be covered with no or low cost sharing. It is the most preventive medicine of any medicine around. It helps people stay healthy, helps them live. That is preventive care. Now, until though the rest of our healthcare system follows us, we're working with the system we have, which right now has some people paying $300 or more for a vial of insulin. But here's the catch. It is true that insulin is very expensive. It's also true that what people pay is highly variable. Now, these are actual numbers from our CEO who uses insulin in his insulin pump and is in a health plan that has full rebate pass-through. So any discounts that are negotiated for his insulin gets passed through to patients at the pharmacy counter, which is something that we really push for, because it actually means instead of paying $334 that his pharmacy benefit manager says that insulin costs, even though that's higher than what the manufacturer said it should cost, he was paying $83, which he thought was a really good deal, until he learned that his very same insulin is available for less money outside of his very good insurance plan. So again, when we look at layers of truthiness, when we try to solve problems, it is really important that we look beyond our diabetes specific lens and our diabetes policy lens to understand the context of why things are the way they are. For example, it is true that insulin prices are rising. Here we see a significant increase in list price over the last less than 10 years. But it is also true that we have the list price going up and the true cost, both to health plans and people who buy their insulin outside of insurance, the costs are going down. But instead of patients actually benefiting from it, we have intermediaries who are gobbling up that spread instead of sharing it with the patients who actually require that insulin to live.
Hey, Erica.
You bet.
I mean, I get that, but I'm assuming that there's probably a lot of confusion about understanding insurance plans and your health plans as it relates to all these prices. Can you talk about some of the work that DLC does to help with understanding insurance policies, practices? Because this is a pretty complex.
We could spend an hour talking about insurance and still just scratch the surface. But part of the little niche I think that DLC has carved out in advocacy is we really bifurcate what we do. We focus on these big, meaty issues with government policymakers, but we also work with employers because those employers are making the decisions that impact the health and access to care for their employees. That's not changing a law. That's talking to HR and make sure that they understand diabetes and what it requires and how their policies of restrictive formularies or prior authorization or high cost sharing is negatively impacting their people with diabetes. So again, I'd like to not take us through our insurance rabbit hole, but in another slide or two, we have a demonstration of why it really is important to understand the actual information and how that information might be packaged in such a way to misinform you, misdirect your anger or passion. Because if you're just mad at your insurance company, if you're just mad at manufacturers, I assure you, you're missing out on an entire population of other folks you should be mad at. And advocacy can help you understand how to fix some of those bigger problems. So part of the reason people, not just with diabetes, but chronic diseases in particular, really suffer with prescription costs is that our nation insures them differently than everything else. So here is an example of some lab tests that were billed at $775. Now, that's not just the list price of whatever Quest Diagnostics told the insurance company it was. That's what Cigna told us that it cost. But hey, they negotiated this huge discount of 89% and they shared it with me, which makes us feel really, really good. So we paid the discounted rate because we were members of the insurance plan. With prescription drugs, it is just the opposite, and it is a free-for-all. Now, one of the sources I had listed in our previous one about sources you can go to really kind of understand what is going on in prescription drug pricing is Adam Fine and the Drug Channels Institute. And his quote, and I pull this out a lot, is pharmaceuticals are the only part of the US healthcare system in which the difference between listed net price is monetized as rebates and redistributed to intermediaries, which are very big words and a fancy way of saying we are making sick people pay too much for their prescription drugs so that companies can benefit. And these are companies throughout the supply chain. So when we look at, for example, advocating for rebate pass-through, it is because we know on average, insulin is marked up 80% or more in rebates. All brand prescription drugs are marked up by about 50%, which means people are paying too much for their prescription drugs so that others can benefit. So again, looking at where these numbers come from, we have CVS and other pharmacy benefit managers that are owned by or own an insurance company. So you have the insurance company works with a PBM who also controls the pharmacy chain, and now they're actually buying up physician practices. So they just have self-dealing up and down. So they tell you which pharmacy you need to go to fill your prescriptions, whether or not it works for you. They tell you how much was the amount billed. They tell you how much the discount is, which may or may not be sharing all of it or maybe sharing none of it. And they tell you what you owe. So I'm going to stop there. Again, we're going to try to not go too deep into the insurance rabbit hole. But if there are questions or frustrations, or if I've said something that you don't understand or you want a little background on, we're happy to kick the tires and make sure everybody walks away with today a better understanding of what's going on in the policy advocacy space. And again, hopefully challenges each other's thinking. So again, when we have information, misinformation, and inequitable access to information or inequitable access to care, this is what we experience. Again, the health inequities of non-white people with diabetes. You have less access to a CGM, less access to insulin pumps, less diabetes education to learn about these new technologies. You're less likely to be prescribed newer types of insulin and glucagon medications. Again, these are standards of medical care that our non-white people with diabetes have reduced access to. And then we also have, as a result, the real impact is impacts on your health, both long-term consequences, severe, hospitalization for hypoglycemia and DKA, deaths related to COVID-19. I think the COVID pandemic, frankly, laid bare the impact of information and misinformation. Again, spreading misinformation about the impact of vaccines or what they could do or what they were really designed to do. What they're really designed to do is to protect people who are at risk for complications from COVID-19. So what I don't want to walk away from today is doom and gloom, because there really has been, I think, more recognition on the landscape that we need to first understand these inequities, and then we understand why they are happening, and that's how we make informed decisions about how to fix them. I'm going to look at the chat. So before we jump to real world data, Amanda, do we have any comments in the chat that we want to circle back on?
Well, I just want to chime in and say this slide is a perfect example of how implicit bias can translate into complete tangible health outcomes. And in the chat, someone said, working in the healthcare field, I've been extremely challenged by coverage of medications with new weight loss drugs for patients like Ozempic. They are demanding use of alternative medications that are less effective and or having to jump through hoops with a prior authorization to cover the cost.
All right. So the first thing to understand with these formulary restrictions is, one, The formulary restrictions happen because whoever manages that formulary is using it to negotiate discounts with the manufacturer. It is pay to play. So it might not be on the formulary because they are trying to get bigger discounts from the manufacturers, which they might or might not share with patients. More often than not, they don't. But they also are imposing barriers because they don't want you to take it. These companies don't just put these barriers in place. They actually get paid every time a prior authorization is filed and they need to adjudicate it. And every time there is an appeal, they get paid to adjudicate that. So it's almost like this self-perpetuating, it's lucrative. It is lucrative for them to have restrictive formularies. And unfortunately, frankly, people with diabetes are exposed to more formulary restrictions than any other disease state area. One, by virtue of the number of people, but two, by virtue of the types and the number of medications that are required or devices and technologies that are required to manage diabetes. You know, I would say you need to have a good partner in your provider, because this, you know, prior authorizations is a persistence game. It is file it, file the appeal, file it, and do not accept no for an answer. That's all it takes. They are counting on you to say no. So don't let them have the satisfaction. You see Don. Non-white people with diabetes are less likely to be referred to mental health care. And when they are, oops, sorry, it just scrolled. When they have less access to psychologists and therapists. I think one of the areas of change that I think is making a difference as well is making sure that a lot of these psychologists and therapists, these providers, look like the communities that they're treating, right? I think that, you know, there certainly is making sure that we have providers who are empathetic, who understand and are within those communities. I think it just helps establish better layers of trust. And yes, cost of medications is frustrating. And this is specific, especially if they are on Medicare. So Medicare has done a lot. They're making a lot of progress in terms of improving coverage, but at the same time, it is really hard even to pick the right plan, right? Because it's not just picking a plan. You need to pick the plan that covers most of your prescriptions, which is really confusing when you're an older person who might be doing this using a book instead of the internet. Or, you know, again, we have a lot of information asymmetry that makes it really hard to make sure that people with diabetes in Medicare get access to the care they need. Again, we're going to talk about areas or opportunities to advocate, and that is one area where there's actually really rich and ripe opportunities to make a difference. So again, when we look at these changes, one, there is hope and there's progress. Two, when we look at these problems, we really want to make sure we have our facts right, so we are solving the right problems instead of barking up the wrong trees. I'm not sure if you have folks from T1D Exchange, part of the virtual summit, but they are doing remarkable work despite their name on both type 1 and type 2 diabetes research, and access to, again, equitable access to medications and technologies. So in the diabetes space and in the policy space, we find there are very few people who make better decisions with less information or with lower quality information. So we have two actual quotes, one which hopefully makes you happy and one which makes you mad. And I will say these are both from members of Congress, and both of their votes count, and they count equally. So when we meet with our representatives, when we share stories, not just of type 1 families from the suburbs, or again, we need to have more voices, more representation of people of color, of different experiences with diabetes, to make sure that we have more members who see access to insulin or coverage of CGM as a life and death concern, and fewer members who will just say, get up and move and make lifestyle changes, and then the insulin problem will magically solve itself. So I promised I wouldn't get too mom-ish in this presentation, but I do feel like it's really important as a diabetes community that we act like one. It seems like there has been some proliferation lately of, frankly, behavior that we wouldn't tolerate from our children. So we certainly shouldn't tolerate it from other adults, and we can choose to proliferate or support it, or we can choose to silence it, or at least quiet those disruptive voices so we can focus on what is unifying and constructive and productive. So this actually, again, is not from Lincoln and not from his Facebook post. It's from one of our board members. It's just a reminder that we need to be consistent and consistently responsible. We need to be thoughtful, intentional, and it's really up to us to clean up the mess that is the internet. It can be a powerful tool for advocacy, but it also, frankly, can be used to silence voices that cannot be silenced.
Yeah, hey, Erica. And
Yes.
I think you're spot on about that. I had like 3 thoughts, and one is that we all need to get outside of our own echo chamber and seek facts. And so if we stay informed and we inform ourselves with facts, the second point is that then we need to arm ourselves with data, good data that is factual. And then our power comes from our ability to be advocates. And that means to partner with other organizations that simplify. A lot of times we say, I can't go out and be an advocate because I don't know enough about policy or I don't know enough about diabetes. But the reality is your power comes with partnering with others who may have more facts to deal with you. And,
Exactly.
and in that realm, that is how we take back control and power and actually cause changes that are positive in nature for people living with diabetes.
Exactly. And I think it is so meaningful and so powerful for people to share their first person experiences. So we can combine facts and information, stats and statistics, but what really drives it home for policymakers, employers, other decision makers is to understand real stories from real people, because that's where you, again, focus on solving the problems that are true, instead of, again, barking up the wrong tree.
And don't be afraid to share your story. A lot of organizations will give you form letters and say, send this letter. The last thing that our congressmen want are these form letters that all look the same. What they respond to is your personal stories. So you take that and don't be afraid to share your story, because that is what makes a difference.
Yeah. And it's funny, I think what we found too in our advocacy, whether it's virtual meetings with members and staff, whether it's in-person meetings, sometimes people are reticent to share their stories because they feel like they're not bad enough, right? Well, I can afford my insulin, or I just have my new, I just got a new pump and it's working with my CGM and things are going great. Why would I advocate? Or they feel kind of like a hypocrite, right? For advocating, for these things, for example, in Medicare, which is a program that they're not part of. But what policymakers really like to hear or need to hear is how vital those things are to your diabetes management, how it makes you successful, or how it maybe makes it easier, but there's more work to be done. But why then it is also important for other people to have equitable access to those same things. So again, all voices have value, all voices need to be heard, all stories need to be told. And in the diabetes community, I say we always have an embarrassment of riches. We have so many really active organizations and advocates who are engaged in the space, whether it's insulin affordability. We're doing a lot of work right now collaboratively with JDRF and with the ADA and the Association of Diabetes Care and Education Specialists, looking at CGM and pump coverage within Medicare. Whether you know it or not, Medicare really struggles to keep up with coverage of technology. So we have a lot of people who are aging into Medicare and losing access to these items, or they can't get them covered at all. So we're working right now with CMS to change that. So when you sign up to be an advocate, there's an open meeting right now coming up on November 15th, where if you want to file your comments to make sure that CMS understands how important it is to improve or modernize their coverage of pumps and CGM, you can share that story. So we've got a couple ways that you can sign up to do that. If you've got your phones, you can hold it up to your screen and snap that QR code where it says advocate. That will take you to DPAC's page to sign up to be a DPAC advocate. And that's what kind of gets you into receiving newsletters, information, calls to action. So really starting to learn what's going on in the diabetes community and weighing in. And that's not the only game in town. So we encourage you to become a DPAC advocate and share your story, but also sign up with the ADA and with JDRF or with other organizations who are working on issues that matter to you, because it's not exclusive. You know, again, we all are kind of working on different issues or from different angles, and your voice has value. So make sure, again, that you're sharing it. Please, 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 if you leave with anything from today, it is to burst that bubble and make sure that you're not just hanging out in your safe place echo chamber with people who agree with you all the time, because that's really where we start to lose sight of how we make progress.
And our power is in our numbers.
Powers in numbers.
1 million people with in the United States with diabetes. Our power is in our numbers. Exactly.
If people with diabetes voted as a block, boy, we could change things pretty quickly, couldn't we? Mm-hmm. Finally, you know what? Help each other. We are right now in a place where the insulin affordability landscape has changed radically. We have people who aren't insured and could be affordably insured with, for example, subsidized individual plans on the exchange where their insulin costs are capped, or where we're working to improve coverage of technologies and other medications. We need to help each other. We can't have any more people rationing insulin. There is help available. We just need to reach out. So part of what we're hoping people will do is not just connect on the internet, but connect with one another. Diversity in Diabetes has their Diabuddies. Diabetes Sisters has their Pods meetup. Step away from social media. It's okay to take a little break and try and connect with real people in the diabetes community, because that's how we learn from one another. And finally, vote. Coming up on Tuesday, you have a mail ballot. It's probably too late to mail it, so drop it off. If you're in line, don't get out of line. Vote, vote, vote.
Wow. Thank you so much, Erica, Amanda, and Edward. This has been such an impactful session. And if I can say anything resonated with me, it was hearing real stories from real people. And the fact that you shared, you don't have to be a policy expert. You don't have to know all the ins and outs. I'm a certified diabetes educator, but I haven't been clinical in probably 8 years. And I have to remind myself, Quisha, it's okay. You don't have to know how many class of drugs are on the market now. As long as you're doing something, as long as we're partnering with others, we can get something accomplished. This has been wonderful. We don't have time for questions, but please, is there a way that anybody can contact you if they have questions or want to connect with you? You're welcome to put your contact information in the chat. At this time, I'd like to thank everybody that has joined. We're going to go ahead and end this session in exactly 1 minute. So I'll give about 60 seconds for everybody to put their information in the chat box. We will be starting right at the top of the hour with our next session. Please go to the VFAIRS platform to join Creating a Culturally Responsive Treatment Plan. Look forward to seeing you all there. Again, so excited to have you all join us for this 2-day event. Thanks again to our wonderful presenters. Look forward to seeing you over the next 2 days. This has been awesome. Take care.
Thank you, everyone.
Thank you.
Casey, if you'll go ahead and stop.